Bismillah ar-Rahman ar-Rahim. It's my pleasure to continue with you the lectures of cerebrovascular disorders. Today's lecture is Diagnostic Approach of Cerebral Strokes. The objectives of this lecture is to know how clinically approach to a case with suspected stroke, and to know the types and the importance of radiologic and the lab investigations of these cases. To reach your diagnosis in most of the neurological disorders and other branches of medicine, you have to answer three questions. The first one is there a lesion in the nervous system or not? If so, if there is a lesion in the nervous system, where is that lesion? It's anatomically the site of the lesion. What is the lesion? What is the lesion? This means the pathology. Is it vascular? Is it demyelinating? Is it infectious? Whatever the kind of pathology. So in case of suspected stroke, we have to take a good history, a thorough history. This history attempts to distinguish stroke and TIA from potential mimickers such as migraine, and we have a kind of migraine which is called hemiplegic migraine, and focal seizures, like motor or sensory attacks of focal seizures on one side of the body with the face, and these patients known to have epilepsy, focal seizures, and might be the first presentation in the ER. So you have to get the full history. It is the first time to happen. Anything before the attack happens, if the patient known to have migraine or epilepsy on medication or without medication, whatever. So you have to take a good history to differentiate between stroke and TIA and other potential mimickers. Also, you have to know the onset of the neurological deficit, which is in case of stroke typically sudden or rapid, and symptoms just varying according to the site of the lesion. Also, you have to comment on the underlying factors for this stroke or ischemic insult or hemorrhagic insult. You have to know the history underlying these factors. History of heart disease and the peripheral arterial disease is very essential. History of atherosclerotic risk factors like hypertension, diabetes, mellitus, hyperlipidemia, smoking, sedentary life, family history of stroke. History suggesting thrombophilia, hematological disorders, trauma, neck, face, and head pain. This might suggest arterial dissection. Also, to exclude or rule out endocarditis, you have to ask about fever, chills, cardiac symptoms, or drug abuse. You have to comment on the precise time of symptom onset and any problems that might contraindicate thrombolysis, which is a medication given in the first 4.5 hours. So you have to know the precise time of symptom onset. This is regarding the history. Let's go to the examination. The examination is divided into two main parts: general physical examination and neurological examination. General physical examination is very important and sometimes missed by our colleagues. We have to check the temperature, the blood pressure, the cardiac rhythm. If the patient is having high temperature, high grade fever, in some cases of cerebral insult related to infection, meningitis, encephalitis, might be low grade fever with epilepsy. The blood pressure is very important as a risk factor of stroke, especially if the patient is having hemorrhage. Also, on the long term, it affects the blood vessel wall, and makes it more prone to thrombus formation. Cardiac rhythm, to get an information about the stroke, if it is cardioembolic due to atrial fibrillation or valve disease, the quality of carotid pulses and the presence of bruit, also very important to check the neck and the carotids, the quality of heart sounds and the presence of any murmur. Very important, the physical examination, general physical examination. Don't miss it in every patient with suspected stroke. Then the neurologic examination, which is very important to define the neurologic deficit. Is it unilateral, bilateral, or there is lower motor cranial nerves on one side and the contralateral side there is weakness or hemiplegia or hemiparesis according to the extent of the lesion. This allows classification of the event into one of the clinical stroke syndromes like anterior circulation, posterior circulation, brainstem, whatever the clinical syndrome, and this will allow prediction of the vessel involvement and the mechanism of vascular occlusion, as we mentioned earlier in the first lecture, that if the patient is having a problem in the right carotid artery, which gives the right ophthalmic artery, also the posterior communicating artery, and the two middle and anterocerebral arteries, the two cerebral arteries. So if the lesion or the problem in the right carotid artery, it will affect the vision on the right eye, and the contralateral side will be hemiplegic or hemiparetic according to the extent of the lesion. So this will differentiate transischemic attack due to carotid or carotid transischemic attack from the vertebrovascular transischemic attack, and also can give you an idea about the localization of the disease. The prediction of vessel involvement and the mechanism of vascular occlusion. Is it embolic or thrombotic? If it is sudden due to an impulse came from the heart, or gradual, or rapid due to thrombus formed on any intracranial vessel, and so on. Let's go to the localization. How to localize exactly the lesion, the site of the lesion, the site of the lesion per se. Is it cerebral, brainstem, or spinal? According to the criteria of the signs and symptoms and your examination, as we see in this figure, the pyramidal or the motor areas of the brain, the fibers goes down in the corona radiata, then the internal capsule, then the brainstem, then the cassette and the lower part of the medulla. 80% of the fibers goes to the contralateral side. Any lesion in this pathway can give us some information about from the signs and symptoms about the site of the lesion. So if the patient is having a problem in the cortex, small vessel in the cortex, small infarction in the cortex will cause some symptoms. In the coronary data or subcortex or subcortical region will have different symptoms or more extension of the symptoms and signs. If it is in the internal capsule, you will see another symptoms, maybe more extensive. And the brainstem has its specific criteria of cross the hemiparesis. In the cervical region, which is rare to have a stroke in the cervical region, but other etiology can cause cervical hemiplegia, or we call it sometimes in the hemisection of the spinal cord Brown-Sequard syndrome, and you will study that in details with the spinal cord disorders. Now we will start by the cerebral hemiplegia or cerebral stroke. Cortical, from the cortex itself, 3 C's and AHM. The 3 C's are coma, convulsions, and contralateral cortical sensory loss. comma if the lesion is extensive, because if small lesion cannot gives comma, but they should be large, very large, and suddenly happen a massive infarction to lead to coma. Convulsions if the lesion is irritative in the cortex. Contralateral cortical sensory loss. It's cortical sensory loss due to parietal lobe lesion. Agraphia and aphasia if the lesion in the dominant hemisphere, which is usually the left side, the left hemisphere. Homonymous hemianopia. This is a field effect due to parieto-occipital lesion. The lesion is usually presented with monoparesis or monoplegia, because the lesion is very, taking apart, not the whole part, the whole pyramidal tract neurons, only one part, so it causes monoplegia or monoparesis. Subcortical, it's a little bit the same but more extensive because more fibers may be affected. Capsular, all these fibers collected in a bundle that goes through the internal capsule, so complete hemiplegia can happen with upper motor facial palsy. Contralateral hypoesthesia, the sensation will be diminished on the contralateral side. Hemianopia may occur. This is optic radiation. This is due to lesion, the optic radiation. No convulsions, aphasia or agraphia, because it is away from the cortex, so the convulsions, aphasia or agraphia usually not happen with the capsular lesion. Despite that, there is what's called subcortical aphasia, but this is for the postgraduate, not for the undergraduate. Brainstem lesions. Let's start with the midbrain. Midbrain, as we know from the anatomy, that we have 12 cranial nerves, not 12 separate, but 12 pairs of cranial nerves. The first, second, and eighth are purely sensory, and they are not connected to the brainstem directly, and we will not see these nerves affected in cases of brainstem hemiparesis or hemiplegia. In the midbrain, the third and fourth nerve there, so if there is a problem in the midbrain, we can see Weber syndrome, hemiplegia on the opposite side of the lesion, always, as we call the cross the hemiparesis. Always the hemiplegia or hemiparesis will be contralateral to the lesion, and the cranial nerve will be ipsilateral to the lesion. So in case of Weber syndrome, hemiplegia on the opposite side of the lesion, and oculomotor nerve paralysis on the same side of the lesion. Benedict syndrome is the same as above, but with hemiataxia. The hemiataxia on the opposite side due to red nucleus lesion. The bones will find two syndromes, Millard-Gobler and Foville syndrome. So Millard-Gobler syndrome, the same, hemiplegia on the contralateral side, sixth and seventh nerves paralysis on the same side, which is, as you know, the seventh cranial nerve hooks around the sixth cranial nerve and the bones. In the bones, there is fifth, sixth, and seventh cranial nerve. Foville syndrome, hemiplegia on the opposite side of the lesion, and loss of conjugate deviation of the eyes to the same side of the lesion due to medial longitudinal bundle lesion. So if there is hemiplegia on the contralateral side, if the lesion on the right side, the hemiplegia will be on the left side, and the conjugate deviation of the eyes to the same side of the lesion. If the lesion on the right side, the hemiplegia will be on the left side, and the conjugate deviation of the eyes to the same side of the lesion is lost. I mean, the patient cannot move his eyes towards the side of the lesion. Let's go down to the medulla. The medulla, the American pronounce it medulla. Medulla is, there is two syndromes also. There are two syndromes, the Aviles syndrome and the foveal syndrome. Aviles hemiplegia on the contralateral side of the lesion, and ipsilaterally there is 9th and 10th cranial nerves affection. Foveal syndrome, hemiplegia on the contralateral side of the lesion, and ipsilaterally the 10th and 12th cranial nerves are affected on the same side, ipsilaterally. The spinal, as I just mentioned now, it's not common, and if you want to diagnose spinal, you will not find any cranial nerve affection, no headache, no vomiting, no symptoms or signs related to the brain itself, but mainly it will be paralysis below the site of the lesion, but the lesion should be above C5 to get the upper and lower limbs at the same time. Very important to know what are the causes of transient hemiplegia. The differential diagnosis of the transient hemiplegia. Transient ischemic attacks, we mentioned it in the first lecture. Hypertensive encephalopathy, hemiplegic migraine, now one of the mimickers of stroke, as we mentioned earlier in this lecture. Cerebral aneurysm, multiple sclerosis, post-epileptic, we call it Todd's paralysis. The patient may stay paralyzed on one side if this focal epilepsy for maybe 3 days, 72 hours. Congestive attack of general paralysis or insane due to syphilis, or hysterical, and this term is obsolete because hysterical came from hysteris, which is a uterus. This is for diagnosis for females only, but nowadays the term has been changed to be a convergent disorder because these disorders affect both male and females. So what are the investigations of this case? In the case of stroke, urgent brain CT scan is the most important lab test for all patients suspected to have stroke. So once clinically diagnosed as organic hemiplegia, not functional, or convergent disorder or hysterical, urgent CT scan of the brain must be done. The CT scan should be non-contrast. Non-contrast, I mean I don't have to give the patient contrast or dye to do the CT scan. This makes it very easy and very rapid. Search for the etiology and risk factors. So first of all, you have to clinically diagnose, and after that radiologically diagnose. In the same time, don't waste time. Okay, once suspected, go directly to the CT scan. So computerized tomography scan of the brain is the most important investigation for every patient with suspected stroke. Then search for the etiology and risk factors. This is not at the time of doing the CT scan. You can withdraw blood sorry, and take it for lab investigations. Neuroimaging. The goal of acute neuroimaging to define the site of any established infarction when possible and the extent of ischemic tissue at risk. So to know the site, where is the site of the ischemia or infarction, and the extent around this core of infarction of ischemic tissue at risk of more infarction or more death of brain cells. Second is to identify the site of an acute vascular occlusion, where is that vessel, which vessel is occluded. Also to identify hemorrhage or unexpected other lesions mimicking the cerebral infarction. So the non-contrast CT scan exclude hemorrhage from the start if the patient is having recent stroke and you don't know if it is hemorrhage or infarction. You can exclude hemorrhage from in the first few minutes of hemorrhage, but it is insensitive for acute infarction when done within hours of stroke onset. So if the patient comes in the ER with suspected stroke and you did a CT scan for this patient, non-contrast CT scan, and you didn't find hemorrhage, now by exclusion with a finding in history and examination, now the patient is having ischemic stroke. So you have to do your management according to the CT scan and your examination and the exclusion of hemorrhage. Do your management of ischemic cerebral stroke directly without waiting for more investigations. You know what's called the early signs of CT scan, but this is for postgraduate, not for you. This figure shows the CT, computerized tomography or CT scan of the brain of patients, different patients. Patient A is having ischemic stroke. Patient B is having hemorrhagic stroke, intracerebral hematoma with ventricular extension. Patient C is having subarachnoid hemorrhage. In patient A, you will find something, this dark area with the arrow, white arrow. This dark area means it's not that dark, but it is, darker than the brain tissue itself, and not the same darkness of the CSF. This is an area of ischemic stroke. It's not for the first day, I think, because you can see its boundaries, and the density is high, hypodensity. So this blackish coloration means there is infarction in the anterior cerebral artery and part of the middle cerebral artery, or mainly the anterior cerebral artery. Patient B, this is hyperdense area, means whitish in color. This is hemorrhage in the brain tissue, and as you can see in the posterior horn of the lateral ventricle also is having some hyperdense areas. This means intracerebral hematoma with ventricular extension. In patient C, you see the interhemispheric blood, which is whitish in color, and here also in the sylvian fissure, this is subarachnoid hemorrhage. To differentiate between the hemorrhage and the infarction on basis of brain CT scan or non-contrast brain CT scan. So more advanced radiological investigations or more evaluation, I mean, for the blood vessels and the area around the core of infarction, CT, computerized tomography, angiography. This rapid anatomic evaluation of the cerebral vessels, starting from the aortic arch through the neck and intracranially. So you can see the tree of arteries coming from the aortic arch. The left internal, the common carotid artery comes directly from the aortic arch. The right from innominate, the common carotid, then subclavian. This from the innominate artery on the right side, but in the left side, the subclavian comes directly from the aortic arch, and the common carotid also comes directly from the aortic arch. The common carotid, as you know, divided into internal carotid and external carotid. The internal carotid enters the skull and gives off the ophthalmic artery, middle cerebral artery, anterior cerebral artery, and the choroidal arteries, and the posterior communicating artery. So this is a tree, and after that the anterior cerebral arteries unites by the anterior communicating arteries, anterior communicating artery that communicate between the anterior cerebral arteries, and posteriorly the internal carotid artery communicate with the posterior cerebral arteries by the posterior communicating arteries to complete the circle of Willis. So you can see all this by the CT angiography. CT perfusion is important for giving us an idea about the size of infarction and the area around this infarction with hypoperfusion of blood, and this area is at risk. We call it penumbra area. Let us go to another modality of radiological investigations, which is very important also, the MRI and MRA. MRI is more sensitive than CT scan for early infarction, as we do what's called the DWI, which is diffusion weighted imaging. In acute stroke, you can see a bright area within minutes of infarction. Not like the CT scan, you can wait even to 48 to 72 hours to get the infarction, to see it on the CT scan. So it's better to do DWI or diffusion weighted imaging for the infarction. You can see it in the first few minutes. And to differentiate this, or to get more information about these white or bright lesions and differentiate from other causes of bright lesion, we can do what's called ADC, which is apparent diffusion coefficient. This is also a modality of MRI. MRA, like CTA, can define flow in the cerebral vessels from the aortic arch also to the intracranial arteries. MR perfusion, the same like CT perfusion, also can define the tissue at risk with hypoperfusion. These are examples about the MRI with diffusion weighted imaging, MRA, and follow up after medication. And the first line, the panel A, you can see left middle cerebral artery stroke. You know, the CT scan, MRI, on your left hand side is the right hemisphere, and on your right hand side is the left hemisphere. So just pretend the patient is, you know, lying down on the couch and his feet towards you. So on your right hand is the left hemisphere, and your left hand is the right hemisphere. So in this picture, in this figure, in panel A, the infarction here is on the left middle cerebral artery. This you can see it, the blue arrow, and the yellow arrow shows the MRA. You cannot visualize the left middle cerebral artery. And the last figure on the panel A, you can see reperfusion again of the middle cerebral artery, and the thrombus or embolus now has been removed or dislodged with the reflow of blood in the middle cerebral artery. With you can see it by yellow, by the arrow now. The color is light blue arrow on your right hand side. Let's go to the second panel, which is panel B. This is an infarction or ischemia in the right middle cerebral artery. You see it by the green arrow. This is whitish area. We call it hyperintense lesion or bright lesion. The red arrow and both MRA and follow-up MRA showed no improvement or no recanalization of the artery. This means that occlusion of the artery without improvement after medication. Conventional angiography, to define the vascular pathology, it's more sensitive and specific than other modalities of arterial investigations like CTA or MRA. It remains the gold standard for diagnostic vascular imaging. This is the picture of angiography, conventional angiography, digital subtraction angiography. Carotid duplex also is important. Doppler imaging of the blood flow, velocities, and anatomic imaging by gray scale and color flow techniques. It is now available, widely available, non-invasive. In good hands, you can divide carotid lesions. Transcranial Doppler ultrasound, the imaging of blood flow in the cerebral vessels, the major vessels and of circle of Willis. We can get information from the direction and the velocity of flow, the site of stenosis you can detect it, the vasospasm, and also you can assess the pathway of collateralization. The lab test, we can do a electrocardiogram, we can do cervical chest x-ray, glucose, electrolytes, blood urea, nitrogen, creatinine, CBC, platelet and PT, prothrombin time, and INR, international normalized ratio, activated partial thromboplastin time, ESR, blood culture, and the echocardiogram for the if the fever or cardiac murmur is present, to exclude or to rule out or to prove the endocarditis. Toxicology screening, sometimes the patient after drug abuse can get something mimicking stroke or actual stroke. After this acute phase passed, you can do more investigations to get the cause or to know the cause of the stroke, echocardiography, cardiac rhythm monitoring, further definition of cerebral vasculature if you didn't do the angiography, additional lab tests to know the risk factors like the glucose, fasting glucose, lipid profile, homocysteine. Lastly, we can do a transesophageal echocardiography. This is very important to detect aortic atheroma, valvular heart lesion, and left atrial appendage, which is in some cases the transthoracic echo cannot visualize it. This is about the how to approach to the patient with a stroke. As we mentioned, just to summarize, we have to rapidly diagnose the patient using the taking a good history. The history you can take it from the relatives and any bystander see the patient in the acute phase of the stroke. And after that, you have to examine the patient, and you have to stress on the general physical examination. I mean the blood pressure, temperature, and the cardiac rhythm, the pulse. And also you have to check the carotids and the heart very well. After that, neurologic examination to decide which side of the body, what are the cranial nerves affection, is it only upper motor neuron facial on the same side of hemiplegia, or contralateral side lower motor neuron, if the ipsilateral motor cranial neurons affection, cranial nerves affection on one side, or and the contralateral weakness or hemiparesis or hemiplegia. This is across the hemiplegia, means the brainstem affection. And after that, after the clinical diagnosis, you have to do the CT scan. I mean, if you decided that it's a organic hemiplegia or organic lesion, the patient is not hysterical, there is no situation makes him doing like this, and your examination decided there is actual weakness and there is actual stroke, you have to do brain CT scan as fast as possible. The CT scan very important to do it in the first few minutes to exclude hemorrhage, the first of all. And after that, if you find there is no hemorrhage and no, even if there is no infarction, this is by exclusion, this is infarction, but you cannot see it in the very early hours with the stroke. So you have to start the specific medicine that we will talk about in the next lecture, inshallah. So you did CT scan, you withdraw the lab for the further investigations to if you decide to start the TPA or thrombolysis, you have to do the INR, you have to do all the lab, CPC, and all the important lab just before, and the blood sugar, the random sample, and also blood pressure is very important to check it before you start any thrombolysis. So now you finished all these investigations, the acute one. So goes after you finish the acute investigations, and after the patient is settled with good medication, everything is done for him. You have to search for the cause, for the etiology. You have to do the CTA and or MRA to detect the vessel affected. Also, you have to do echocardiography, either transthoracic or transesophageal, according to the, if the patient is young, it's preferable to do a transesophageal echo. And sometimes if you have, vague CT scan results, you can do a very rapid diffusion weighted imaging of the MRI. You can see the bright area of lesion in the MRI in the first few minutes, so you can, take your decision on a good results. So this is for now for the diagnosis, how to approach a patient with stroke. So next lecture, inshallah, will be about the medication or management of a patient with acute ischemic